right, thanks very much for that. And thank you, everybody, for staying to the end and for being at this conference where the focus is on restoring health, not just managing disease. I'm Matt Phillips. I'm a neurologist in New Zealand, and I'm going to be talking about ancestral strategies as therapies in glioblastoma, a very terrible and aggressive brain cancer. And I'm going to be speaking alongside my colleagues, Marilyn and Martin. I'd like to start with a quote on survival. A great man said, "The most important factor in survival is not intelligence, it's not strength, it's adaptability." That man was Charles Darwin. Darwin is often ascribed or credited with this quote about survival of the fittest. And when you say that, connotations of some super strong or super fit person come to mind, or organism, but really it's about adaptability. That's the key. And that's what Darwin meant. Perhaps adaptability is the key to survival in cancer too. So let's look deeper. I have to start with this slide on the somatic mutation theory of cancer. Why? Because it is embedded in the consciousness and subconsciousness of mainstream medicine today. The current main theory on cancer says that you start out with a quiescent cell, and that mutations occur in the nucleus, which is a bundle of genes within the cell, and these mutations cause problems, and they come from many different sources, and the mutations are mostly random. Over time, years, decades, more random mutations occur in the nucleus. Some of these are activated growth-promoting oncogenes, and some of them are inactivated tumor suppressor genes that, when normally in their non-mutated state, prevent excessive growth. And this theory states that this is why cancer occurs. And it's been around for about 100 years. So again, it says that genetic mutations are seen as the primary cause of cancer. The competing theory, the contender, the up-and-coming, is the mitochondria dysfunction theory of cancer. Now, mitochondria, as I'm sure everybody knows, there are 1,000 or 2,000 of them in almost all cells, not red blood cells, but all the others. And they are commonly known as the powerhouses of the cells. They run around the cells and produce energy. There's a lot more to them than that, which I'll talk about in a few slides. But this theory basically says these mitochondria are exposed to various insults, and over years or decades, you get damaged mitochondria in a certain part of the body. Cancer arises in many different regions. The damage accumulates, subsequently leads to mitochondria dysfunction, which itself is a simplistic term because they do so many things. The cell faces an energy shortage, and many cells with damaged mitochondria will simply die, but some don't. Some hang on, and they hang on by using a different kind of metabolism whereby they can start cranking up their glucose intake by like 10 to 100 times or more. And this is called the Warburg effect, and they rely on this alternate pathway bypassing their damaged mitochondria. There's another one called the Q effect. They can use another amino acid called glutamine, but I won't talk too much about that. So they basically erect these plan B methods for getting energy. Over time, they still get the random mutations. This theory is still concordant with the idea of random mutations. Why? Because although they are making enough energy to survive, it is not optimal, and you need energy to repair mutations that occur all the time in all cells on a daily basis. Also, there is this thing called a stress response that occurs. When the mitochondria are damaged and stressed, they send signals back to the nucleus, and those signals activate these growth-promoting oncogenes and inactivate tumor suppressor genes. So you still have those too. Okay? So it's all consistent with what we know happens in cancer, and that causes cancer. This theory is the flip-flop, the polar opposite of the somatic mutation theory, because it says that genetic mutations are a response, a downstream effect of the cause of cancer, which is the mitochondria health. So mitochondria dysfunction is seen as the primary cause of cancer in this one. If you want to read more about that, published a paper on it last year that you can Google and find quite easily. Now, what are ancestral strategies? These are strategies or methods that are based upon ancient human practices. I'm going to briefly outline the two most powerful and important ones, my perspective, and then we'll move on. Fasting is one of them. And fasting can be done through prolonged fasting or intermittent fasting. Prolonged fast, basically at least 2 days of fasting, up to 3 weeks. You can actually go a lot longer if you want. You need water and you need salt on those long fasts. Intermittent fasting is where you fast every day, usually up 12 to 24 hours, technically up to 48. So it would be 2 days. And you just need water. You don't need extra salt for those. Tea and coffee is kind of optional on both. There's some debate about that. The other ancestral strategy that I'm going to talk about is the ketogenic diet. I put diets in quotation marks because I see these as methods for getting the body into a certain state. They just happen to be diets. They're high in fat, adequate, or even a little high in protein, but they have to be very low in carbohydrate. And they should ideally be based on pre-agrarian unprocessed foods. The further back you go in time, the better the food is generally going to be. And possibly the best ketogenic diet is Sophia Clemens, a Hungarian scientist who uses this Paleolithic ketogenic diet. It uses very, very old kinds of foods. But the point is that you want to use real food, and real food actually changes the further back you go in time. And any cuisine works. Any ethnic kind of diet can work because it's a method, not a diet. Why view these strategies as ancestral, and how can they benefit anyone in the modern era, particularly people with cancer? So let's look at humans as agrarians, farmers. Human agriculture has existed for at least 10,000 years, maybe 15, 20,000 in certain areas. And these ancient Egyptian paintings clearly show agricultural practices. Agrarians were able to have regular meals throughout the day, and they were able to increase their carbohydrate content because they could grow crops, rice, grains, barley, that kind of thing. The modern dietary lifestyle, in its current form, which is sort of 4 to 5 meals a day, 3 meals a day, plus a couple snacks, high in processed carbs, and unfortunately ultra-processed carbs, that's less than 1% of agrarian time. It's nothing. So we now eat 4 to 5 times a day with ample processed carbs, and we've had insufficient time to adapt to this. But what about humans as hunter-gatherers? Humans have actually been on the planet evolving through different species of humans, but still humans, for 2 to 3 million years. The agrarian lifestyle is less than 1% of that. So how deep do you want to go, is the question. I want to go deep. We've been agrarians for less than 1% of this. So we've actually had insufficient time to adapt to a crop-based diet as well, or a crop-based dietary lifestyle. We are largely adapted being a hunter-gatherer. What is that? So what is our natural state? It's been said a few times here, but I'm going to push this home. We generally believe it is normal to be mostly in an agrarian, fed state. I call it glucosis. I think I coined this term. I've never read it anywhere, but I need an opposite of ketosis, and I'm calling this glucosis. Most people in the West, almost everyone, are running on glucosis. Basically, glucose is like the dominant fuel by a wide margin for their brain and muscles and the rest of our organs. If we look at modern hunter-gatherer societies and look at the different sub-environments that they live in, these guys in the northern latitudes are on a ketogenic diet. In the temperate latitudes, they're on a low-carb diet. In the tropical latitudes, particularly the grasslands, they have the highest carb intake. It's a low to moderate carb diet still. It's not moderate to high, and it sure as heck ain't high. And there's no resemblance to the Western diet there. Plus, there's lots of fasting. If you want to read about this, Andreas Hahn and colleagues came out with this paper a few years ago, but there's a number of other ones that have similar findings. There are always exceptions there too. I'm looking at the broad brushstrokes. There's always one tribe somewhere that does something a little different. That's okay. Now, hunter-gatherers ate intermittently with fewer carbohydrates. And those guys that had low to moderate carbs, when they had them, there was a ton of fiber in there, right? Because it wasn't ultra-processed. So they had a lot of fiber, which mitigated the damaging effects of the carb hit on your bloodstream. So if you look at this, keto, low carb, or low to moderate carb, plus a lot of fasting, plus some calorie restriction, I'm sure of it from time to time. Never mind the changes in exercise and sleep and all these other wonderful things. These guys, these hunter-gatherers, were in a state of physiological ketosis. Everywhere in the world, most of the time. Not all the time, most of the time. That state is associated with a low blood glucose, a high level of blood ketones, which are energy molecules that come from fat. And this state leads to a host of other potential anti-cancer changes that I'm going to talk about soon. This is why cancer was relatively rare in our hunter-gatherer ancestors, probably. Even deeper, let's look at our fundamental essence. We do believe cells are the fundamental essence of life, and that the mitochondria are the powerhouses of the cell. That statement denigrates mitochondria to being just an energy source for cells. If you look at mitochondria, though, what they do, okay, sure, they make ATP energy. They do that. But look at everything else they do. So they make molecules that have signaling functions within the cell. They are involved in the release of neurotransmitters. They generate hormones that signal outside the cell, throughout the body, in fact. They are involved in genetic signaling within the cell, and they actually, to a degree, coordinate the expression of the genes. Heck, they even control when the cell lives or dies through cell apoptosis signaling. These are not just powerhouses. They do a lot more. If you want to read this paper, Dr. Martin Picard and colleagues came out with this last year. Excellent paper on all the things mitochondria do. I argue our essence is our mitochondria. As an aside, to Dr. Schofield's comment earlier, yes, mitochondria are made of atoms, so are cells. Everything's made of atoms. But I'm talking about life and health. It's mitochondria. They don't just produce energy, and they have multiple roles. I see them as coordinating the cells. Cells aren't the fundamental unit of life. They're infrastructure for our mitochondria. If you took a snapshot of Earth from space and you didn't know anything about it, and you saw a bunch of houses and cities, you'd think those were the fundamental units of the network of life on Earth. What about all the people that run around the houses and move from one house to another? Mitochondria move from cell to cell, by the way. We know that now. That's new research, new findings. I argue cancer occurs when cells break away from their damaged coordinators. The mitochondria are needed to keep the cell in check. Ancestral strategies induce modest oxidative stress through low-carb diets, and they induce sufficient renewal processes through the fasting. The Western diet is a problem because it creates a metabolic gridlock. You can't metabolize high carb and high fat simultaneously as a mitochondrion. It's really tough. It gets overwhelmed, and a ton of reactive oxygen species get generated, and all these other bad things occur. Low carb allows them to metabolize one source at any one time, the fatty acid oxidation, keeping the carbs down. They also need these fasting periods, long fasting periods, at least 12 hours, probably more, to renew. Mitochondria can renew, mitogenesis, mitophagy, getting rid of the old garbage ones. They can do this. They're amazing. They are incredible. They are our life. So what are the primary goals of ancestral strategies for anyone, everyone in this room and everyone on the planet, I would argue? The primary goals are this: to sustain our natural state. This is a mind flip. Our natural state truly is physiological ketosis. It's not glucosis. And our fundamental essence, I think, truly is our mitochondria, not our cells. Proper implementation of these strategies creates a balanced oscillation between feeding and fasting, which gradually optimizes our mitochondria to become better at dealing with stressors. That is, more adaptable, as Darwin suggested initially. That's called mitochondrial hormesis or mitohormesis. Mitohormesis leads to optimized mitochondria function, optimized mitochondria adaptability. That, in my opinion, is health. So what are the goals in cancer? It's a little trickier because cancer represents the body in a different kind of state. So in cancer, these ancestral strategies, if we look at it from an iceberg approach, that's supposed to be water with a tip of an iceberg. Yes, they starve the tumor of glucose, as pretty much everyone knows. Yes, that's the idea. You want to lower the glucose, reduce the tumor's main fuel supply, deprive them of their Warburg effect, while raising ketones. You can measure the ratio of glucose to ketones in the blood. It's called the glucose ketone index, or GKI. You want a low GKI, because that means you have low glucose and high ketones. This is thought to weaken cancer cells, but let's go deeper. If we use keto diets, especially fasting, what we can do is induce a state called differential stress resistance. That means you make normal cells enter this resilient state because when there are low nutrients available, they hunker down into a stress-resistant mode and become more resistant to every stressor, including chemoradiation. At the same time, you actually create a state of differential stress sensitization for the cancer cells because they can't do that. They keep trying to grow, but you've cut their fuel supply. So you protect the normal cells from the chemorad while you keep hitting the cancer cells. Let's go deeper. What else do these things do? They lower growth factors. Cancer is a disease of abnormal growth. They change gene expression. They basically induce the expression of genes that do not favor the cancer state. And they activate immune function. If you can activate your immune system against tumor cells, that's fantastic. That's just a really great way to do it. But at the bottom of this iceberg, way down, which nobody really sees, not really, is we're trying to restore our natural state and our fundamental essence. Physiological ketosis, mitochondria. So maybe these can be promising as cancer therapies. That's where I'm coming from. So to look at this theory is wonderful, but you have to show or see whether it's true or not. Truth is all. We're running a clinical trial. We're investigating a metabolic therapy program, which we call an MTP. The metabolic therapy program is basically ancestral strategies in people with newly diagnosed glioblastoma, GBM, and we're integrating these ancestral strategies into the standard treatment protocol in a pulse press approach. Pulse means you exert an acute pressure for a finite period of time, and then you have a press, a milder pressure for a long period of time. Metabolic pressure on the cancer cells in this case. And Dr. Thomas Seyfried coined that term, not me. So we are doing prolonged fasts in our patients, 5-day fasts, 5 days without food, just water and salt, a bit of tea or coffee, and they are strictly timed with the standard treatments to acutely exert maximal metabolic pressure. We start the big 5-day fast 3 days before the chemoradiation come on board. We get that GKI down, we get the glucose down, the ketones up, cell hopefully entering stress-resistant mode, then you hit with the chemoradiation. Cancer cells are struggling for their glucose, hopefully they get hard, the normal cells are ready for it. This is the idea. This is what we're trying to do. I'm not against the standard of care. We're working with the standard of care. Okay? We're trying to use both. We're trying to use terrain theory and germ theory together. So germ theory, chemoradiation, targeting the cancer, trying to eliminate it. Terrain theory, trying to restore the health of the body. Make sense? Mitochondria specifically. Okay, so that's our pulse. We're also using intermittent fasting when these people are not doing a 5-day fast, they're only eating 1 meal a day, sometimes 2. So they're doing intermittent fasting on the other days, and that's a chronic metabolic pressure, which is a press. And when they do eat that meal, it's a modified ketogenic diet. So that diet is designed, that method is designed to be simple, flexible, palatable, and affordable. It can be omnivore, carnivore, vegetarian. It could even be vegan, although I wouldn't really favor that because it's hard to do. Keto, and it can be any ethnic cuisine, as you'll see. Doesn't matter. It's the same method, different ways to get there. And this is another chronic press. So our objectives, that all said, are feasibility, safety, and efficacy. Efficacy being, what does it do to quality of life? What does it do to survival? We're aiming for 20 to 25 people. We've recruited 13 so far. The protocol is this. This is the most intensive, longest metabolic protocol ever applied to a group of people with any advanced cancer. And it's designed to maximize synergy with the standard treatments. Again, we're not trying to do something different from the standard of care. We're trying to make it better and sort of approach cancer from a different therapeutic perspective. So how does this work? So a person who gets a seizure or speech difficulty or a vision problem or something, gets a scan, a CT and an MRI, and then they find a spot. That spot gets biopsied. And if the surgeon sees that it's obvious tumor, he or she might do a resection of that tumor to the best of their ability. If it is confirmed as glioblastoma, GBM, then our people get 6 weeks of chemoradiation. This is a standard protocol. So the first 5-day fast starts 3 days before that 6 weeks, and there's another one in there about 2.5 weeks after. And the rest of the days, it's 1 or 2 meals a day keto diet. Then there's a break from the chemoradiation. They still do their 1 or 2 meals a day keto diet. Then they have 6 months of adjuvant chemotherapy. It's a real marathon. And we do 6 more 5-day fasts, timing each of these fasts with the 5 days of chemotherapy that they get every 4 weeks. So you start the fast 3 days before day 1 of the chemotherapy. Again, we're trying to get the glucose down, get the ketones up, maximize differential stress resistance, and so on. After that, I've asked every single person who's come out to this. This takes about 10 months. So everyone who's come out to there, I ask, what do you want to do? Do you want to keep going? Every single patient, of course, has decided to stick with their 1 or 2 meal a day keto diet, which we call a time-restricted ketogenic diet because it's time-restricted eating plus a keto diet. And yeah, everyone's continuing. The program is registered here on the clinicaltrials.gov site if you want to see that in more detail. I'll just give you some preliminary results today because we're only halfway through. Feasibility. So is this feasible? It sounds very intensive, and it is. So everyone in the trial is measuring their blood glucose and ketones daily during the standard treatments at the same time of day. Here's our preliminary data in the first 12. So the GKI is on the y-axis, the vertical column, and the horizontal column, the x-axis, is time. Now, at baseline, the GKI, before anyone starts the metabolic therapy, is really high. It's about 18. To be honest, it would normally be 25 to 30, but some people have started their keto diet beforehand. Understandable, right? You want to get on top of this thing as soon as you can. But it's 18 for our participants. That's a blood glucose of about 6 and ketones of about 0.3. You're in ketosis technically when you're at least at 0.5 or 0.6, so they're definitely not in ketosis. This is what most people would be most of the time in glucosis. Now, in the first 6 weeks of chemoradiation, you can see that GKI plummets to a 2. That's a very good GKI. It's very low, and to maintain that for a 6 weeks period is lots of metabolic pressure on the tumor cells. And then over the next 7 months, we are able to sustain that GKI. The participants are able to sustain it at a 2 to a 3, which is fantastic, right? So we've got really strong metabolic pressure being exerted against these cancers for a long time. And so I would say so far the MTP appears very feasible. I'm pretty confident saying that. Could change. We still have another 12 participants to enroll and do this with, but if it's anything like the first half of the cohort, it should be similar. Safety. We're measuring all adverse effects using a scale that the oncologists use routinely called the Common Terminology Criteria for Adverse Events, or CTCIE form. So we're documenting all adverse effects. It doesn't matter where they come from. And after we document them, then using a more focused checklist, we're asking the person, well, do you think this came from the standard treatments or the metabolic therapy program, or did it come from something else? And so far, all adverse effects, all of them attributed to the MTP in the last 2 years, have been grade 1 or 2, mild. Okay? I hope this continues. I think it will, but let's see. So far, it appears very safe. Not last, sorry. We are also measuring changes in body mass index BMI, because this is a common concern of oncologists. They worry about weight loss in cancer, unintentional weight loss in particular, that reflects cancer cachexia, which is a whole body systemic state where the cancer is sort of running away and you're losing muscle, and it's not a good thing. Well, let's look at what's happened so far with our participants. Body mass index is on the Y, the vertical axis, time is on the X, the horizontal. And you can see at the start of this trial on the far left, before commencing the metabolic therapy, our average participant was a BMI of about 28. So overweight is 25 to 30, obese is over 30. So high overweight, and that's not surprising, I guess. After 9 to 10 months, you can see that the 3 bars on the right are in the normal BMI range. So we're looking at a BMI of 23 to 24. That is a perfect BMI. That is a target BMI. That's what you want for health. And I would argue that in the saying of an intentional weight loss, this is intentional because of the metabolic therapy program and what it does, this normalization of the BMI is positive. So far, I would argue the MTP appears to lead to a normal BMI, not a low one. We're not making people underweight. We're making them normal weight. They're making themselves normal weight. Okay, lastly, efficacy. We are looking at a wide variety of efficacy outcomes. Efficacy is how well does this thing work for what people really care about, which is, things like, will they continue to perform well and function, daily function? Will they be able to exercise with the same intensity and the same activity? We're We're looking at the quality of life, hugely important. One of the best things you can ask a person for, I was speaking to Dave about this yesterday, I think, over the next few years is not an objective measure. If you ask them, do you feel healthy? That is one of the greatest predictors of how they actually will be health-wise in a few years. It's entirely subjective, but very powerful. So quality of life instruments are very important in these trials. And lastly, yes, we are looking at overall survival. Do you live longer? So it's health span and lifespan. I cannot give you those results yet because I do not know them with certainty. I am encouraged. However, maybe in a year or two, if I'm invited back, then I can talk about this trial more and those results. Now, I'd like to talk about Marilyn, because I'm going to talk about Marilyn and Martin, who are two of our wonderful participants, our pioneers in this trial. I met Marilyn and her husband Wayne 2 years ago. Marilyn had been diagnosed with glioblastoma, and you can use cancer calculators. There's a really good one online that's very accurate to calculate what someone's probability of survival is based on their age, gender, tumor type, and so on. She had a 50% chance of surviving. That's just surviving, not surviving well, surviving to 2 years. She enrolled in the metabolic therapy program. Wayne was extremely supportive. He even did some of the 5-day fasts with her. And she, after a few months, I gave them a booklet. They follow the booklet for a few months till they get the hang of it, and then we say, if you want to shift this to any kind of cuisine or whatever, you go for it. You want to go carnivore? Fine. Vegetarian? I would be fine with that. She decided to go with a Maori ketogenic diet. How's she done on that? Marilyn actually had 2 tumors, which is a bit unusual, 2 GBMs. The larger one was sitting in her speech region, so she was actually mute at one point. She couldn't say a word. It was also in the arm and leg region. So she was only able to have a biopsy. They couldn't even operate on either tumor because it was just in too eloquent an area. This is at Marilyn's scan, at the tumor's sort of largest early on. So that scan on the left, imagine she's lying on a table with her feet coming out towards you. And the one on the right, she's side profile. You can see her eyeball. She's looking over to the left. The tumor is outlined in the yellow rectangle. The white area is the active tumor. There's little bits of dark. That might be necrotic tumor or inactive cells, but there's a lot of active tumor there. That's just the big tumor. I haven't shown the smaller one. So in the last 2 years, both her glioblastomas have receded, and that was her last scan, I think, a week ago. So very good. Her speech has almost come back to normal. It's about 90%, I'd say. And Marilyn continues her time-restricted Maori ketogenic diet to this day. Martin. I met Martin and Gail 1 year ago. Martin was also diagnosed with glioblastoma, and statistically, his tumor was a bit worse. He only had 1, but it was bigger, and Martin's gender and age were against him, and the tumor type as well. So he actually had a 50% chance of surviving to 1 year, not just surviving well, but again, just making it to 1 year. He enrolled in the program. Gail has been extremely supportive. In fact, she was instrumental in an article that came out in the Waikato Times today about this talk at the Future of Medicine, and also their experiences in the program. So if you get a chance, look at that article. Martin has favored, he's still keto, just as keto as Marilyn, but he's gone for an ancestral Mediterranean keto diet. Totally valid. Martin had 1 large tumor. It was sitting in his visual region. So at one point, Martin had no vision on one side whatsoever. So he was able to get a partial resection, but there was a lot of tumor they couldn't get to. So that was Martin's tumor at its worst early on. And you can see it's the white area is quite irregular and jagged. That's the active cells. There's little bits of white inside it, little bits of active cells inside it, and little bits of dark, little bits of dead cells, and a lot of fluid around it too, actually. Over 1 year, Martin's GBM has also receded. Not 100%, there's still a blip. You can see, if you look carefully, that little tiny white area, that's still there. I'm thinking we're going to have a good outcome here, and that we're going to see that disappear, but I might be wrong. Let's see. Martin continues his time-restricted Mediterranean ketogenic diet to this day as well. So look, considering Martin's at 15 months now, and he was had a 50% chance of even surviving to 3 months ago, this is an excellent result. All right, to conclude, ancestral strategies optimize general health by restoring our natural state physiological ketosis. That's so important to understand, that we're not supposed to be in glucosis all the time. And our fundamental essence, I really think, I might be wrong about this in 10 years, I might look at this and go, oh, what was I thinking? Maybe it's all about atoms. But I really believe mitochondria are a fundamental essence. When you learn, the more you learn about them and see how much they do beyond just making energy, they're incredible. These strategies may be beneficial in cancer, which is characterized by glucosis and mitochondrial dysfunction. And we're applying these ancestral strategies, which is just ancient wisdom, as therapies in glioblastoma. And this is the most intensive, longest metabolic protocol ever applied to people with advanced cancer. It is too early to talk about group results, but I'd like you to now hear about the individual experiences from two of our participants. Ladies and gentlemen, I bring you Marilyn and Martin.
Ki hea te komako e ko ki mai kia hau he ha te mea nui o te ao. Māku e ki atu he tangata, he tangata, he tangata. In 2017, I had a brain scan because I wasn't sleeping properly, and it was cleared. In that time, from 17 to 21, with no warning or signals, I was diagnosed for August. I went home for a lockdown. Home being, we live in Hamilton, but home is Whangarei. We have a house, family house there. And we travelled with our 3 sons and daughters who was in the hostel in Hamilton Boys. Came down, took them back to Whangarei, and spent the lockdown together there. I had a fall 4 days into the lockdown, and Wayne can describe that soon because I'll cry. And then I wasn't allowed to take Wayne or any of the kids with me to the hospital.
Kia ora whaka. So when she had the fall, I was obviously asked if it was a seizure or stroke. And I said, well, I think it's both, because I wasn't sure. So when she went to hospital, obviously we went and had a visit because of the COVID lockdown and also the policies that were put in place with all the hospitals. 2 days later, she was discharged, still having seizures.
And getting worse.
She had some medication there, but it just seemed like she was having from 2 hour gap to about 20 minutes. So she ended up, we got a call back from the neurologist in Whangarei. And she actually found something, so she wanted me to come in. And then basically from there it was organising a biopsy in Auckland. That was the only place they could do it. And then I think it was about 6 weeks later we found out the results that she had this cancer, which was a lesion, not a tumour, which I didn't realise, I didn't know what the difference was. So it couldn't be operated on. At the time, the doctor or specialist at Auckland Hospital said that you'd probably have 12 months to maybe 2 years. So that was a real shock to actually hear that.
And so, like Matt said earlier, I went into the biopsy and came out not speaking. I could murmur sounds but no words. And I taught myself sign language from my phone in the hospital and had to teach Wayne and the kids some signs so they could understand me.
And after finding out what had come out of it, it was obviously devastating. There was mixed emotions. I had mixed emotions. I was angry, scared, you name it. And I think the biggest thing for me was about what could I do to support her? Then the kids, how were they going to react? Because at the time, our youngest was 10, and our oldest was 19. When they were telling us about the radiation, chemo radiation and the therapy, we asked, is there any other alternative, treatment that we could do? And then they did put us on to Dr. Matthew Phillips, who was doing a trial. I think he was just starting the trial at that time. And I remember we left the hospital and then we basically walked. We drove off and then he rang us, so we did a U-turn and we went straight back to him, and then he basically started running through the program, and we were like, fasting 5 days. I thought, that's, it was pretty intense. But what would we do for life? And he talked about adaptability. We had to adapt. We had no other choice. And I said to Marilyn, I saw the program, I was like, geez, that's pretty intense. Then I'll do it with her. With the fasting and all of the diet stuff. And whilst that was happening, she was doing the chemo radiation and obviously lost all her hair, or most of her hair, through their treatment, which was another traumatic thing. We had to go in and get fitted for a week. But in the third treatment, her blood counts were coming back within a week.
For days. Yeah.
So her whole body had changed, and even though she was putting this poison into her body, she was actually recovering a lot quicker, and it just got quicker as she got further on down the trial. And obviously her speech had started improving, her strength in her arms, because she couldn't even take a little for plastic bottle. That's how weak, how weak her arms were. And then she started doing all of that, and and I just, obviously the keto was absolutely a big part of that, the fasting. And I used to tell Dr. Matthew Phillips, I said, why do you're doing this fasting, but then we poison her? She already feels like crap because she hasn't eaten for 5 days, and then we've got to feed this into. But he explained exactly what was happening. And so we just trusted that, and we just adapted to that. And obviously the results speak for itself, and he's definitely onto something around this, and I love listening to his research and his findings.
I just want to highlight May and September MRI scans showed that clear. Yeah.
I'm Martin. I'm currently 68 years old, recently retired professor of music at the University of Waikato, where my specialties were composition and musicology. And one of the great joys of this treatment, against the odds and against my expectations, I've actually begun to go back and compose music in the last few months. I was diagnosed with GBM, and it came as a bolt from the blue, especially when we learned it was unmethylated, which is harder to treat, and it was stage 4, so actually one of the worst types of cancer you can get. And all the literature confirms it's incurable, and the standard treatments are poor, I think. The standard treatments, from what I can see, haven't changed for about 70 years, which is surgical resection, if possible, followed by chemotherapy and radiotherapy. And despite billions of dollars being done in research, there's no effective treatment for glioblastoma. The prognosis is terrible. And I knew from the stats I would die within 12 weeks without treatment. Then I had to wait to see if I would be eligible for treatment. And that was an agonizing wait. And I eventually got the call and said, yes, we will operate. And it'll be followed by chemoradiotherapy, which I was enormously grateful for. Just to go back a step, looking back, I can see now, leading up to that point of diagnosis, there were a number of symptoms, but I misread them. What were the symptoms? Well, there was a vague sense of increasing depression, mood swings and character changes. I became quite grumpy and a bit irascible. And I'm sorry about that. There was, of course, a persistent headache, and it's not like a sharp stabbing headache. It's one that's like something, well, I described it as being a head being put in the vice, and the vice over months being screwed up tighter and tighter until the day of crisis. I felt like my head was going to implode. Ironical, really, because when I saw the scans, I realized the tumor was going inside and pushing out. It was really compressing the brain horribly. I felt I was living in a thicker and thicker mental fog. And given my job, supervising PhD students, leading the department at the university, all these things, I just, in the end, couldn't. It became harder and harder to do. In the end, I couldn't. I also had memory issues. And the most notable thing was steadily deteriorating vision, which got worse and worse. So back in March of last year, I had a cataract surgery to try and fix this vision problem, which had a brilliant effect in one eye, great vision. But I still had trouble reading. I went back and back to get new prescriptions. And eventually the optician was the person who spotted something was seriously wrong and said, look, the optical dysfunction you've got doesn't square with the symptoms you're describing. You should see a doctor immediately. So I did. I went from there to the medical centre, and from there I never went home. I was taken by ambulance to the hospital, and within about 3 or 4 hours I was diagnosed with a brain tumour. I remember the conversation about the diagnosis very clearly because a very gentle, empathetic doctor in the middle of this busy ward drew the plastic curtain around a tiny shred of privacy and came and said to Gail and I, look, we've found a mass in your brain. And Gail said, what does that mean? Is that a tumour? And he replied, yes, I'm afraid it is. At which point I asked him, is this likely to be fatal? And I certainly will never forget his next 4 words, saying, yes, it is. I'm sorry. And at that point, the whole world turned upside down. My planned retirement of 20 years of writing music and spending time with the grandchildren just was smashed, and I had to resign myself to what seemed inevitable. So I, of course, began putting my affairs in order and all that kind of thing, and telling the children, which was just awful. We did what had to be done, and the next stage was to go into the hospital and have, a craniotomy. And this was 5 hours face down surgery. The back of the skull is split open, and as much tumour as possible is taken out, as you probably know. Earlier, when I was given this terrible news about the GBM, and like Marilyn and Wayne, it was such a shock to get this prognosis of imminent death and nothing you can do about it, that I said to the oncologist, look, okay, I have to deal with this, but is there anything I can do myself? I had to ask that question as well. This was not offered. Is there anything I can do? Diet, exercise, special foods, supplements, going somewhere different in the world? And he replied, no, not as far as I know. But there is a trial going on. So if you want a referral, I can give you that, and you can find out more about it. It's to do with diet and its possible effect on GBM. So thank heavens he said that. We asked for the referral, got it straight away, and 2 days later had the 2-hour screening interview with Matt. which was an absolute life changer, a life saver, of course, because the prognosis was so bad otherwise. That explained the MTP, what it was, the science behind it, which I sort of understood partly. I was still in a state of shock, and it's quite a radically different way to think about health. All the things I'd learned, or many of them had to be unlearned, like fat is not your enemy. The more fat, the better. So I now try to eat 75% fat, 25% protein, 5% carbs, and 0 sugars every day. Which again is kind of the food pyramid upside down. No, I haven't had a coronary. I have a lot of salt, and guess what? My blood pressure has come down after decades of battling it. So I just had to go and trust, and it's working. It's working for me. I've been part of the MTP trial since that interview. Matt pointed out quite clearly that there is no guarantee with this trial. It's a clinical trial. It doesn't have a cure for cancer, not a panacea, but this may help, and here's why. But it's a hard yards that you have to do. And I said, okay, I'm desperate, I will do it. But I've told Matt this previously, and he won't mind my saying it, but I was totally skeptical. I thought, I know I've read about GBM, it's a horrific disease, there is no cure, it's defeated science for 70 years. How can changing my diet possibly be a significant weapon against this ferocious disorder? But I had nothing else. I come from a research background. It's in music, but I know what research is and how to do it and how to sift information. And the more I read about it, the more I thought, actually, this does make sense. From what I could understand of the biochemistry, that makes sense too. From my experience, what's the difference between standard treatment, which is surgery, radiotherapy, and chemotherapy? What's the difference between that and the metabolic therapy program? Because I've had it all. The first thing you really notice is on the metabolic therapy program, as the patient, I'm given agency. That is, I take control of my health back. When I go into the other therapies, the surgery, I lie on the table, my head's cut open, and they do magical things. In chemotherapy, I just accept the poison that's injected into my veins, hope it's the right amount at the right time, and same with radiotherapy. Metabolic therapy, it's entirely up to me, so there's nothing to stop me going out and eating a sugary dessert, after this conference. But I don't. It's all a matter of mind over matter, really. And the stakes are so high, because I know if I do go back and eat carbs and sugars, the stats tell me I will get sick and die. So I haven't found it that hard to completely change my lifestyle. The other thing I'd notice say about the differences between MTP and the so-called standard treatments is that with the standard treatments, the specialists focus on managing a part of a disease. You've got cancer, it's in your brain, it's this type, I'm going to do this to try and kill it. And that's what each one of them does. But after that, and this literally happened, I completed the treatment. They said it went well, here's the letter to the hospice. So, have it in writing that if things go really well for me, I could live 12 to 15 months. Well, I'm just beginning month 15 now. And I can tell you, it's not checkout time yet. I have to think of food as medicine rather than as pleasure or reward. And also, it's not just something to do with socializing. So that's a big mind shift, and I still struggle with that a bit. But, of course, you can make keto food delicious. The other thing is how to stay determined and positive. And as I said earlier, I bring all those tools that I can to it. And most of the time I do. I enjoy every day. Every day is a good day. So the challenges for me on the MTP are primarily psychological. It's about getting your brain, or your mind, brains, shouldn't use that with him, get the mind to enable the performance of this and to stay positive and focused, not looking at the final outcome, but step by step. And I have to say, crucial has been support from Matt, who's just the most amazing physician. And I've dealt with a lot of physicians lately, but he's exceptional. Thank you, Matt.